Thank you, Danielle, for that warm welcome and thoughtful land acknowledgement. It's now my pleasure to introduce Dr. Risa Freeman, the DFCM Vice Chair of Education and Scholarship, to introduce our keynote presentation. Dr. Freeman's a community-based family physician affiliated with North York General Hospital. She holds a cross appointment in the School of Graduate Studies, Dalla Lana School of Public Health, Division of Clinical Public Health, and membership as a clinician researcher, education researcher at the Wilson Center. In all of these roles, she enjoys working with learners from across the continuum of medical and interprofessional education. I think we all know Risa as an incredible mentor and leader in our department and a fierce advocate for all things medical education.
Good morning, and thank you, Allison. Before I introduce our keynote speaker, I'd like to tell you a little bit about Walter Rosser, our former chair for whom this day was named. Walter was DFCM's first resident. He was in a class of one in 1969. His willingness to blaze new trails, his we can solve and do anything attitude, and his ever-present optimism were just a few of his many special attributes. Walter returned to the DFCM in 1991 to serve as our chair, a position he held for 10 years. He was a passionate educator and a keen advocate for education scholarship. He was also a prolific researcher, and he received the Order of Canada for his contribution to primary care research. Even with that tremendous academic career, Walter never lost sight of his true calling as a family doctor. He was humble, kind, and patient. He was generous, and he had a genuine interest in everyone that he met, and he was especially devoted to providing care to the underserved. While he was here in Toronto, that included providing care for patients at the Wellesley Hospital and the Don Jail. His patients were primarily living with HIV/AIDS in the earliest days of that pandemic. Now let me turn our attention to our keynote speaker, Dr. Lawrence Lowe. I was told that I had 2 minutes to introduce Lawrence. That's not nearly enough time to do justice to his journey thus far in medicine. So I'll share just a few highlights, if I may, about his tremendous accomplishments. After attending school at the Western University, Lawrence came to the University of Toronto and enrolled in the concurrent family medicine and preventative medicine program in 2006. He completed his family medicine residency at St. Mike's in 2008, and then earned a Master of Public Health at Johns Hopkins in 2010, before completing his public health residency here in 2012. For more than 10 years, Lawrence served in senior medical leadership positions in the public health sector. Among his many roles in 2 different provinces, he was the senior medical consultant in the office of the Chief Medical Officer of Health for Ontario and a medical consultant to Public Health Canada. Many of us know Lawrence best for his role as the Medical Officer of Health for the region of Peel during the COVID pandemic. Lawrence, we are all so grateful to you for being the voice of reason, calm, and courage during those days. My family and I would hope that you would be the speaker on the morning TV show. You brought your training, often in the car, that was so good. You brought your training as a family physician and a public health expert to make the incomprehensible understandable. You were honest and reassuring at the same time. You courageously led your team and mitigated the pandemic's impact on one of Canada's hardest hit communities. You stood up and you brought attention to the most vulnerable, something that we all aspire to do and teach our learners to appreciate. Lawrence is currently an adjunct professor in the Dalla Lana School of Public Health and soon to be a faculty member in the DFCM. He became the executive director and chief executive officer of our College of Family Physicians in September of 2002. As you know, our college has embarked on a bold new plan to examine our residency programs. Known as the Outcomes of Training Project, we have all been called upon to think about what works well and what we might do differently to ensure that our grads are equipped to provide comprehensive primary care in the future. And even though we are only in the earliest days of working together on this project, I can attest to the support and advocacy that Lawrence has already shown to us. We live in a turbulent time. Now we're called the family medicine crisis. Lawrence, with your deep experience as a clinician and a public health leader, I cannot think of a better person to lead us through these choppy waters. Sadly, Walter Rosser passed away in October, and we miss him. Lawrence, if he was here, I know that he would be delighted that you are our keynote speaker because you share many of his most admirable attributes: a willingness to blaze new trails, to serve the underserved, and to show courage in providing care to the most vulnerable. I should note, though, that there is one thing that our speaker has on Walter, and that is he's an accomplished musician, something Walter was not. Many of us had the opportunity to see his talent firsthand when he got on the stage and rocked out on a keyboard at the Section of Teachers dinner last fall. Lawrence, we hope to have many more occasions to join you in song in the future. And now the mic is yours.
Thank you so much, Teresa. I wrote, when I was writing my notes, I wrote here, thank you to everybody for your warm welcome, but I didn't realize just how warm it would be. And in reflecting on things, I have to say it's a tremendous honor to be here as a former chief resident of the St. Michael's program, co-chief resident, I should. We were actually three, a troika, we called ourselves. And also having graduated from what I think were some of the greatest preceptors at 61 Queen. It is a bit of coming home in a way to be able to speak with all of you this morning. And I will say, in thinking around some of the strange constraints that life has placed on us, I wasn't able to join you here nearly as early as enough as I needed to, because I needed to pick up a rental car because my previous one was totaled a couple weeks ago. And unfortunately, these 2 days also coincide with the board retreat and strategic planning session that we're having with the college out in Mississauga. So I will be taking that rental car right after my talk. And just like the guy that quits the open mic after his song is over, I'll be driving over to Mississauga to make sure that the board is there and that I'm able to engage the strategic planning session with them. But they did know that there are so many supporters of the college here at DFCM and so many people that have been champions and leaders and past presidents and past board members of the college. There would be no way that I would turn down this opportunity to both speak in the name of Walt Rosser, but also to provide all of you an update from where I've gone. In fact, I see this as a bit of an opportunity for me to share now 9 months into my role at the college, what I've seen and hopefully continuing to learn from all of you with your august experience and your background to really see how we can continue to grow the specialty and our collective efforts together. So all that said, we'll move to the next slide, please. Actually, I can do that myself. Sorry. Great. So, so the title actually says, the title is what I've reflected on in the idea of from strength and study to team-based care, our future being together, the strength of our collective voice as family doctors and as healthcare providers in terms of driving solutions to some of the crises that we're facing today. I also wanted to highlight that it's interesting. You'll notice on some slides, I'll draw on something where I'm talking about something really far in the past, and we're now thinking about the future. And I'll mention something more closer in contemporary parlance and contrast that with Risa's remarks around Dr. Rosser. So some people are talking about the past, I'm talking about the future, and then we're kind of filling out the whole complement of the timeline of our specialty and some of the leaders and titans that have served it. In terms of my conflict of interest, sorry, I didn't realize the bullets came out that small, but in essence, I have no other conflict of interest to declare other than I'm an employee of the CFPC and serve at the pleasure of the board of directors. And I've also received honoraria from the Toronto Metropolitan University and have various academic affiliations, including with Dal Lana and also Queen's University. And also I'm the MEDS 2006 alumni coordinator for the University of Western Ontario, which reminds me that I need to put together our 20-year reunion in a couple of years. So I did want to mention Walt Rosser, and now nearing my 9th month in the CEO of college, I come with great humility in coming to present a lecture in the name of Dr. Rosser. His passing actually came just days after I started my tenure at the college. In experiencing and reflecting on my own knowledge of his stature, as well as the outpouring and commemoration of his career that followed, I've come to learn that Dr. Rosser exemplified throughout his leadership a commitment to the highest ideals of the college as a clinician, teacher, researcher, and leader. And I only hope that some of my remarks today befit the dedication he demonstrated in all those arenas, which was critical to the advancement of our specialty. I thought it very apropos as well that the theme of your conference this year is strengthening health systems through academic excellence, connection, and collaboration. I will say I'm not surprised, having known Dr. Daniel Martin for some time in medical school, that the idea of collaboration and being stronger together would be something that she comes up with. You may notice similar themes in my talk as well. I also wanted to note something special, that in 2024, the College of Family Physicians of Canada will celebrate 70 years since its founding. And I think it important for me to say here that as the only national medical institution that is dedicated exclusively to the interests of family doctors and the specialty of family medicine and the primacy of family doctors as that of the healthcare system, I know all of you who are supporters of the college understand that we are an important and leading voice in addressing the current challenges that beset our healthcare system. But I also know that we as the college cannot possibly do this alone. We are not possibly going to succeed in supporting and strengthening family medicine on our own. So my remarks today are designed to reflect on the history and the impetus of the college since its inception, and then draw that into the future to think around our current context, some of the current efforts I've identified, to listen and learn from members, and to think about a future working together in partnership. I want to also cover off the areas of focus that I've identified in the early part of my tenure. Success on these fronts are absolutely necessary, first to advance the specialty of family medicine. But again, I really want to underscore that as I'm talking about this, I want you to understand that I know that we will be depending heavily on the support and collaboration from family medicine leaders at the University of Toronto, among other academic institutions, and a plethora of interest holders across the spectrum. First comes to first, though. Let's talk a little bit about what we're facing. We are now 3 years since the World Health Organization declared a global pandemic, which they recently called an end to the emergency phase of last week. One in which we recognize has had significant impacts to disruption to society, as well as to our healthcare system. Now, granted, some of that disruption has been positive. Certainly the advent of virtual care as a viable tool that family doctors might deploy if it's deployed appropriately. But I would posit that on balance, the pandemic has actually amplified the extant challenges and gaps that we in health and healthcare faced prior to its arrival. Throughout the pandemic, we saw how the emergency drove worse outcomes for populations that already faced inequities at the outset. And in fact, we must not forget that those same populations now also face a longer road to recovery. We also saw worsening mental health, delayed and deferred treatments, surgeries, procedures, and challenges with accessing procedures, a climate of misinformation and distrust of the medical establishment, as well as, frankly, of each other in society, that contributed to burnout through greater quantity as well as complexity of care, more abrasive patient interactions, and more punishing workloads for providers, including family doctors across the system. And as we all know, I'm often fond of saying, family doctors and public health are in the community. They're the front line that's outside trying to keep this from getting into the acute care system. So it's important for me to reiterate 2 points here to set the context that I always take every opportunity to highlight, one of which may be self-evident to many of you as family medicine leaders, and the other that may draw strong reactions depending on how you viewed the emergency response to a novel, fast-moving human health crisis. So first comes to first, the less controversial one, perhaps. I think we all know that a strong primary care system with family medicine at its heart is fundamental to any high-performing healthcare system. Hospitals provide excellent but expensive care that is limited in capacity and should be reserved for the most urgent needs in our communities. The hospital's bailiwick is often curative care over a limited time linked to focused disease experience, instead of the preventive focus, the continuity, and the valuable understanding of context that family medicine actually undertakes. That is that which is critical for the optimal management of insidious, undifferentiated problems that may declare themselves over varied time periods. The reality is that anything and anyone beyond what an overwhelmed primary care system can bear ends up in hospitals. And that often represents both a mismatch of care for the focused resources that exist in the hospital setting, but also results in a backlog for those who require timely access to services guided by the referral of a primary care team that includes the expertise of a family doctor. In essence, it really backlogs the entire system for everyone that is in it. I often am fond of saying as an analogy that family medicine and primary care at its core is about adding life to years and years to life. And it is about keeping patients out of the hospital and the acute care system in the workplace. And many of you may have heard me say this before, but hospitals really are like the courtroom in the legal system. You don't actually want to be in court unless you absolutely have to be. That brings me to the second point in respect of the broader impacts of the pandemic to the healthcare system. We know that the backlog, the mental health impacts, and the institutional distrust that emerged in the wake of COVID-19 is deeply concerning. But one thing I wanted to share is my view that there are certain colleagues that have suggested that the emergency measures, such as lockdowns measures or the decision to pursue community vaccination that were deployed in response to the pandemic, were to blame for these broad impacts. And to those colleagues, I always posit a question. Do we blame the evacuations ahead of a hurricane for the societal disruption that ensues? The reality is that I firmly believe that most reasonable people will understand that it was the emergency that was the root cause of these problems, not the measures that were taken to protect life and limb as the crisis was unfolding. No doubt there's definitely lessons that can be learned and things that could have been done differently. But I think the pandemic needs to be recognized in and of itself like a hurricane, like an unprecedented human health emergency as an incomparable stressor that would have driven many of the same outcomes, whether we took measures or not. I'll use the counterfactual example as an example. We know that in countries that did not close, we saw hospitals that ran out of oxygen and services that were also curtailed as demand for COVID-19 care overran capacity. Those same countries are now also dealing with a backlog and a deficit in care and services. We saw mental health impacts arise as members of their community, and many more members in home and long-term care lost their lives. And then as transmission and linked severity and severity linked with it surged, we also saw the same distrust emerge of officials and of the healthcare system. Formerly disbelieving members of the public who claimed we weren't warned about how badly this might go. How can we trust you again? In fact, on a tour in Tennessee just a few months ago, one of my tour guides in Nashville asked me what I did. And heartbreakingly, once I told her I was a physician, she explained to me that with her very charming Southern accent, that there were actually few people in her community that actually believed COVID-19 was even real, let alone that it warranted any response at all, but that she knew it was real because she had lost people in the pandemic. And that was the moment when I said, that was what we were trying to prevent, that you don't need to learn about this firsthand. And the point I'm making here is that the challenge we face is that all those impacts, all the challenges we're facing with our healthcare system right now in rebuilding, they would have arisen irrespective of whether we chose to take the measures or not. And in fact, given some of the indirect impacts that you've seen in places that did not take the same measures, we would have probably had that above and beyond what we're contending with now. So now that I've set context, we know that COVID-19, the disease, not the measures, really gave rise and exacerbated longstanding deficits with heavy impacts to the well-being of healthcare providers across the spectrum, and especially family doctors and the primary care workforce. We also know that that primary care and family medicine workforce is critical to managing demand for a similarly overwhelmed and challenged hospital workforce. So now I ask the question, what does this mean for the college as we go forward in knowing where the college started and with all of you as partners, leaders, members, a family medicine community that advances, defends, and celebrates family medicine? Well, as it was in the beginning with our initial purpose and mandate, it starts with a few things: excellence in standards in education that are supported by data and research, and increasingly and in equal measure, practice supports in the form of guidance, as well as advocacy for reform, resources, and recognition. Finally, in bringing my lens and perspective of having worked in many different organizations in leadership and management capacities, it also means optimizing and modernizing college processes to ensure that we are effectively supporting our members, driving equity, and working better with our partners. So let me tackle each of these in turn. It's a lot of stuff, and reflect on how they are deeply interconnected one with the other. Anyone read this book? Hands up if you have. I have. I just did. This is a great book. If you don't have if you have a chance to get your hands on it. This is a book called Strength in Study, which is a reflection on the first 25 years of the CFPC. So you'll remember the Walt Rosser piece, Risa covered the early days and I covered the late days. In this case, I've covered the late days of the college, the late days of college I'm going to, but let's go all the way back to the beginning. And I will say, after I read this, I actually wrote about it in the back of Canadian Family Physician, if you haven't had a chance to read that column. And Professor David Woods actually called me up afterwards and actually said, I'm so glad you read the book. I'm glad that you found it useful. He's actually still deeply interested in the life and the history of the college, even though he lives in Philadelphia now. So that was definitely a treat. But I thought this book was really important because it actually gave me insight into what was the core genesis of why the college was created. And essentially, they're the same questions that we are living and working through today. They are living questions, such as, what is family medicine? What is family medicine? What are the activities and values that guide it? What are the standards that we should ascribe to as family doctors? The bar by which we should measure competence for exceptional practice, and the nature of recognition by which we recognize such competence and expertise. And finally, what broad and consistent accreditation and examination process supporting training can account for and also accounting for the diversity of the settings can we use to ensure that our learners learn and our graduates practice in the way that this is envisioned? Those are the same questions that we as a family medicine community through the mandate of the college are still trying to answer to this very day. And so it would be remiss of me in thinking around training, standards, certification, accreditations to not really speak to the emblematic outcomes of training project, which I know Risa mentioned. And this is a really important project that we have embarked on together, and which I will say very humbly, I know many of you have been involved in this project far beyond my own arrival at the college. But as I understand it, the important thing for this project is to really ask the question again, how do we make sure that we can enhance and strengthen training to make sure that our learners are prepared to meet the challenges and continue to practice comprehensive family medicine in today's complex environment? As I mentioned, this important work preceded my arrival at the college, but I understand that the first phase of work was really about understanding what might need to be done. And it did involve quite a broad consultation, as I've been able to review, of many different interest holder groups with the overarching goal of really trying to get to two things. What constitutes comprehensive family medicine today? And how does curriculum, or how might curriculum need to be changed in order to achieve that for our learners, in order to ensure our learners are able to achieve that? I also know that many different interest holders were actually engaged according to their specific area of expertise. And I know that many members have questions, for example, around how were some of these recommendations arrived at in terms of various gaps in training, or the decision to lengthen training, or all these other aspects of the training, of the recommendations of the outcomes of training project. So I understand that they basically conducted a consultation that asked people for the areas of expertise within the what does comprehensive practice look like and what does training look like. And so in essence, members were indeed consulted in identifying what activities and competencies constitute comprehensive practice today. And then that input was basically taken back, compared for gaps, and then put before residency and curriculum experts to say, if you wanted to get from here to there, how do you actually change training? What do you need to do? And it turns out, as I understand, that the complexity of today's work, coupled with the need for team-based competencies, a clear need for more support and supports into transition to practice, led to the decision to add time as a resource to be able to cover all of these aspects in training. And I will share, as many of you are very familiar with, that prior to coming into the role, I did not know this or understand this, as evidenced by some of my previous publications, including letters to the CFP in response to some columns that Dr. Sandy Buckman published back when he was president of the CFP. And I would still state at the outset that I would very much still oppose changes of length in training if it were just being done for the sake of lengthening training. But as a leader and as one who has had to do this in many different settings, and as with all of you, I think we can all agree that it's important to assess the data, the evidence, and context before us to ensure we have a fulsome understanding and interpretation. And I think that's why the second phase that we're undertaking right now is so important. Right now, we're basically trying to figure out what could a strengthened curriculum look like and how ready or how feasible can we get there. I think we do have some good evidence, though, that the current training curriculum may be good enough, but it does leave open some serious gaps in certain areas, such as procedures, Indigenous health, mental health and addiction, culturally competent care, end-of-life care, and indeed that critically important transition to practice aspect in getting into comprehensive care that represents future hardship for graduates if we don't necessarily take this opportunity to shore up their preparedness for a comprehensive scope. I also understand that we are not necessarily setting up our residents for success with the current training program, and that many, at least based on data, are seeking certificates of added competence so that they can ease their transition into practice and narrow their scope away from the provision of comprehensive care, while also accessing remuneration and teams that they can work with. So at its heart, the college's move to redefine standards for certification and accreditation is a recognition that we must reinvent and reimagine training to ensure that family medicine continues to flourish and provide the important support that is needed for our learners and their future patients to be able to practice comprehensively in the future. I will go back to what I said earlier, though, which is that it's important for me to outline that the college fully understands that the change of this magnitude will need to be approached thoughtfully and deliberately. We are not in the process of changing the accreditation standards overnight. The present work underway is aiming to redevelop and define what an enhanced curriculum will look like, and also identify those barriers to implementation. For those of you who are Star Trek fans, we are moving forward on impulse, not at warp speed. We also know, especially, that in terms of some of these things, some of the barriers that face us may be things such as resourcing, funding, et cetera, in order to achieve this transformation. And I think overall, though, the message to them is the same as the message to all of us as we embark on this work together. Family medicine is worth it. Resourcing family medicine is worth it. Ensuring we have excellent training, it's all worth it. These enhancements that we are working on will ultimately support family doctors, the future of family medicine, and our patients. The other thing that I will share, though, is that there's a lot of reasons why people may be choosing focused practice and why they may not necessarily be going into family medicine as well. We know that the choice of specialty is often multifactorial. And so in turning from the work on training right now at this time, it's important for me to highlight the work that the college is also doing in terms of addressing the practice environment. We are committed to ensuring that government hears us, that current members of the college and the broader family medicine community are heard and then are supported in the excellent work that they do across Canada, wherever they may be doing it, in what I often call performing everyday miracles that keep people well and out of the healthcare system, adding life to years and years to life, as I've said before. One of the concerns that people have is that the plans to strengthen residency training may actually decrease interest of family medicine among trainees. To that, I would actually argue that I don't know many residents that choose specialty singularly on the basis of training without an appreciation of what they might be doing in their future practice. In fact, if they do, I might actually argue that some of those folks are maybe not who you actually want in your residency training program, because you actually want people who are coming in willing to be excellent trainees and willing to learn. The argument taken to another analogy would be saying that a trainee might choose colorectal surgery simply because it's shorter than neurosurgery, or that an obstetrical resident might choose to do general OB rather than maternal fetal medicine simply because it's shorter. We know that the choice of specialty is multifactorial, and we do know that beyond length of training alone, it is about personal circumstances, it is about the hidden curriculum, and going back to what I started with on this slide, it is about what will I be practicing in the future? What does my future practice environment look like? Incidentally, that the answer to that question also relates to retention and the work satisfaction and joy of current practitioners. On this front, and considering the context that I set out at the beginning, we know that the current practice environment for many comprehensive family doctors has become increasingly untenable. Administrative burden, increasing patient complexity, a system that is still recovering from the ravages of the pandemic, remuneration that has not kept pace with the work and the nature of care that's being delivered, support in the form of teams noticeably absent as compared to other sectors in the healthcare system. All of these have contributed to burnout, inequities, and disrespect, as well as dissatisfaction. In fact, one academic colleague, and I'm actually curious to see if I managed to get the animation to work. If I didn't, I'll be disappointed. But one academic colleague, though, and I'll let you take it in for a moment, recently shared this. It was Dr. Claire Liddy, by the way. She actually shared this very disappointing word cloud. And this was in answer to the question for students, how do you see family medicine today? I cannot tell you how much my heart sank when I saw this. It was probably the most depressing email I'd read all day, in fact. And it actually, not for anything else for that. And once I'd gotten over myself and said, hey, you know what, you can't just sit there and mope about it, I realized that it also galvanized me, because I realized how much work we have to do before us as a college and as a family medicine community. In fact, that same colleague, so Dr. Liddy actually mentioned that some students even came up after the talk to share that they were actually interested in family medicine, but they were not even upfront with that interest in the group, because they felt their choice would be received poorly or ridiculed. That's very, very disappointing. So if we are to change anything in respect of recruitment and retention, it's training is one part of it. Preparing our learners and preparing the future is one part of it. But in terms of impacts on student interests, we also need to address the practice issues that are hiding in plain sight, like a woolly mammoth under a giant spotlight. Oh, the woolly mammoth didn't come up. Okay. Anyway, there was supposed to be a woolly mammoth that like came right down. All right, it is what it is. And now that you can imagine where I was going with this one. So this is why the CFPC is also advocating more for our members. I think we are long past the point where a stitch in time will save 9. We now need 9 stitches, right? That's really it. And by the way, I was told by my comms team that no one knows that saying anymore, a stitch in time saves 9. I'm like, we're all doctors. We've all sutured something. Come on. No, I mean, so we get it. But frankly speaking, the CFPC, I've been really working to make sure that we are out there with as clear of a voice, especially with World Family Doctor Day around the corner, with the message that I just delivered. Family medicine is worth it, and that you need to invest in family medicine, in team-based care, in administrative supports, in information technology that actually makes our lives easier. I always love the oxymoron of solutions being called solutions when they're actually problems. We need fair compensation that incentivizes complex care over low value and volume. And we also need some sort of supports in place to actually just provide for work-life balance, simply for our members to just have a break. That's really what we're trying to get at. So within our role, the CFPC is working tirelessly to drive that forward, while also working to provide practice supports as it pertains to CME guidelines and practice tools to make it easier for our members to keep up with the ever-changing knowledge base. That work is also vital in terms of some of the practice supports work they're doing. It is fairly nascent at the college, and I will highlight that I think this is an area where we will certainly be working very closely with the knowledge and leaders in the academic field to come. Finally, and this is more sort of inside baseball in a way, but I think it's important for me to share with all of you. This brings me to the last area. So I've talked about the training aspects, I've talked about the practice side. Now this brings me to the last area of focus that I've identified in the college, which is I want to ensure that we are organized, resourced, and equipped to optimally serve our members and advance the specialty of family medicine. We are in the process, as you've heard, that I'll be heading to shortly, of launching a new strategic plan. And by the way, I hope many of you have taken the opportunity to fill out the surveys, to be able to participate in some of the focus groups in your leadership capacity, et cetera. We very much value your input. And your input into what you may ask. We are in the process of launching a new strategic planning process that is intended to update our previous plan, which ran through 2022. Currently, we're in a bit of a transitionary period, myself being part of that transition. But I think being in this state now actually allows us to take stock of not only the broader training and practice questions that I've discussed today, but also how, as an organization, the college will continue to celebrate, convene, collaborate, and connect with our members. Unquestioned to me is the importance as well of having strong provincial and local leadership that brings diverse perspectives of our members from coast to coast to coast. And our strategic plan is thus intended to chart a bold vision and course that will clarify and expand the reach of family medicine. Associated reviews will also look at how we might modernize and shift present internal processes to leverage modern ways of working and technology to enable us to support all the important discussions across Canada in an effective and efficient manner. So I promise I'm getting to the end, but I just wanted to highlight that we are currently listening and learning as part of the strategic planning process. And there are many ways to engage with myself and our current president, Dr. Christy Newton, who I'm pictured with there. We very much welcome your ideas, thoughts, concerns, suggestions, commentary, whatever you'd like to share with us on how the CFPC can work to serve you better as members or work to advance the specialty of family medicine in a more effective manner. And I want to highlight one thing that was very clear when I read David Wood's book, is that the college is only as strong as all of us together. The reason why the college was founded to a large degree was to bring our collective energies together in leading the specialty. And we are only as strong as our collective insights and efforts. So I encourage you to reach out to us. It's also important for me to highlight one important and key priority of our organization, which is working on equity, diversity, and anti-racism. The board has directed that this become a critical priority and focus, and underlying all of our efforts, whether it's training transformation or whether it's practice advocacy for practice reform, as well as any other operation that we're going to have in the college, it is my goal, together with the executive team, to embed equity, diversity, and anti-racism in every facet of the college. Early in my tenure, I had the honor of representing the CFPC at a signing ceremony with the Indigenous Physicians Association of Canada, where the college committed to a declaration for Indigenous cultural safety. Since that time, our team has advanced critical work in incorporating Indigenous health competencies into the Outcomes of Training project, as well as the advocacy that we're conducting for practice reform. And we are also seized at this time with the work of establishing an anti-racism committee that will be supported by an Office of Equity and Inclusion. So, much like the goal of training transformation and practice reform that I've mentioned in terms of meeting the needs and supporting the specialties of today, the work that I've just described in respect of organizational renewal is also intended to modernize the CFPC and place us in a position as an organization and community of family doctors to more effectively meet the challenges of the future. So, in returning to the theme of your conference, it's important for me to reiterate again that the CFPC has a unique role within the healthcare system, but we can't do it alone. Training transformation, practice reform, and college modernization all present opportunities for academic excellence, collaboration, and connection. And so I really want to highlight that the CFPC, as the only national medical organization that is exclusively dedicated to the interests of the specialty of family medicine, belongs to all of us. It belongs to all of our collective hopes and dreams and aspirations for our practices, for our patients, and for this specialty. And since its inception 70 years ago, the CFPC has been able to bring together definitions and standards that have allowed us to stand on our feet and advocate exams that I still remember. By the way, I almost missed my exam because there was no exam center for SUS in Hamilton at the time. And there was a crash on the Gardner and we were trying to get from Toronto. And I remember Nancy Fowler was actually the site coordinator when I was writing my exam, and she sat me down in the waiting room and said, you're here now, just take a deep breath, you're here now, it's all good. But the reality is that's the community. The college belongs to all of us, and it is still answering the living questions of what family medicine is, how it should look, and how we should secure the future for our future practitioners. So I really want to thank you today for the opportunity. We are stronger, in fact, strongest together. I really am pleased to take any questions you might have at this time. Thank you.
Thank you, Lawrence. How fortunate we are to have our leadership in the hands of Lawrence, and his clear thinking, his ability to assimilate large data sets that he's had to work through over the last 9 months, It's really quite tremendous and awe and inspires awe. I had the pleasure of having lunch with Jack Westfall yesterday, who, and we had a chance to compare the Canadian and the American healthcare system. And what was amazing is that the American family medicine system has 5 or 6 different professional bodies, each one sliced up. One does education and one does certification and one does professional identity. In Canada, we have but one. And how lucky we are that you had that for us. So with that, I am going to open it up for questions. We're going to do a little bit of an Oprah Winfrey thing here. Anyone have any questions?
And are these? I think they're on. Yeah, they're on. I'll just pull mine up.
I'm not good at this. Okay. Does anyone have any questions that they would like to ask? Rosemary.
Oh, I can hear you,
I-
but I don't think you're.
I don't think this is on.
Oh, it's on now.
Okay.
Whoa, thank you so much, Dr. Lowe. And I think everyone here is dedicated to family medicine, without a doubt. We're all teachers, academics, but I think really you need to speak to the on the ground docs. They are walking away in droves. I think you know this. I mean, it sounds like you know what's going on, but we need to advocate to the government that if they truly value comprehensive care, they've got to step up. Okay, that word cloud is really dismal, but this is what people are feeling, and they're not walking away or stepping away as soon as they graduate, throughout the entire career span.
Yeah.
Okay, so I thank you for your guidance, and hopefully your vision will come through, but you need to reach the on the ground docs because they are on life support, as many of my colleagues like to say. Thank you so much.
If I could just respond, thank you. I appreciate that. I didn't disclose that I met my wife actually at St. Michael's Hospital when we were doing family medicine residency together. And she is very much a family doctor in the community, practicing in Midtown Toronto without much of an academic affiliation. So I see it at home. I see it amongst all of my my residency colleagues who I've had the opportunity to, and certainly I hear it from our members. And so I'm still early. It's been 9 months and I already feel like I've traveled on airplanes way too much than I had intended. But I'm absolutely of that intention that I do want to get out as far as I can, together with our presidents, together with our board, to really make sure that they understand that first of all, we're understanding them. That's the most important thing. And then in turn that they understand that, you know, the college is here to support them. And we're going to push as hard as we can and make sure that their stories come to light, because the government does need to hear this, and they do need to understand how those tie into the solutions that we're advancing. Appreciate that.
Thank you. And is this mic on? Mic? Okay. Maybe we can just, as you come up to ask a question, introduce yourself so Lawrence has some context of who you are. Rosemary is a community family physician, educator, and leader in Scarborough. And Michelle.
Hi, Lawrence. Michelle Graver, a community-based family physician, newly minted professor. Thank you. And I'm a strong believer in community-based research, utopian, popular, etc., which has had difficulties. Looking at our colleagues in the acute care sector, they have a lot more organizational support. They have people that can help them do quality improvement. They have lots of IT people to help them extract their data and manage it and return it to hospitals for quality improvement, for research through Gemini. We seem to lack this organizational infrastructure because we're still somewhat isolated in small offices. But it's necessary. We can't do this side of the desk on top of all our other duties. And I remember one of Noah Ivor's early studies, and it says, you know, my job is one patient at a time. That's because my job is one patient at a time. You got to help me with practice management. You got to help me with population management so we can do both well. In your view, how do we get past these systemic barriers preventing us from organizing ourselves? How do we get past the large number of REBs that we have to go through for very good studies like Can't Treat COVID, or the 15 REBs for Poplar, the 7 or 8 REBs for Utopian, just to extract data? How do we change the system so it actually recognizes, reflects, and supports community-based primary care and our academics?
It's a great question. I think it starts with change driven by provincial policy to a large degree. And I think this is what, at least at the national level, we've been advocating to the federal government, that this round of healthcare funding needs to come with conditions, with things that basically say, yeah, if the province accepts this funding, it needs to go to primary care and family medicine. It needs to support driving towards team-based care. It needs to support essentially a reorganization of the system. I think we're in a very interesting phase so every crisis usually starts with that. For anyone who's watched movies, I don't know, I'm a very visual person when it comes to some of the artistry. So, like those movies where people they're freaking out and they're just like throwing everything because they're just trying to figure out what might work. We're currently at that phase of the family medicine crisis, where it's literally like, okay, well, maybe if we just, got some more international medical graduates and we just have some more pharmacists being able to prescribe stuff, we're going to solve this, right? And the reality is that a whole system overhaul and rethink needs to be done. I often like to point out that the community is the last place where we don't have teams. You go to a hospital, you go to a long-term care place, you go to a mental health, and counseling facility. They all work in teams. So why is it we don't have the will to actually say it's time for us to recognize that no one person can do it on their own, and we need to organize with the requisite supports in the manner that you mentioned to provide effective and efficient primary care where we are stronger together more than the sum of our parts. So we're going to keep driving that message, obviously, at the national level. Our chapters are driving that message at the provincial level. And hopefully, if we manage to get some policy pieces in place that allow funding to flow directly to where it needs to go and drive transformation, hopefully in the long run, we'll start to see some of the changes that are needed to address the challenges we're facing.
Thank you for that, Lawrence. And I know that you know this, but our department is well suited and organized through the great work of Ava Grunfeld and other great leaders doing the scholarly work and the research in healthcare systems, in education, and making sure that our residents and our learners want to be family doctors and are ready to be family doctors in systems that work. So we hope that you'll call upon us for that. Next, Abby.
Good morning, Abhi Manyasud. I'm faculty with DFCM and primary care researcher. Thank you very much for joining us this morning. My question is about where you see competencies and training around population health and public health fitting within family medicine. I noticed, a couple of the areas that you identified, mental health and addictions, Indigenous health, these are major population health issues. And I'm also reflecting on your McWhinney lecture published in CFPC, where you really identified that a lot of the reflexes in primary care are the same kind of reflexes we need for public health and population health, appreciating uncertainty, complexity, understanding community. Where do you see population health training fitting within family medicine training in the future?
It's a great question. And one that's obviously very close to my heart, given my dual areas of interest and specialty. My view of this has always been that to be an excellent family doctor, you need to be able to understand and use and advocate for things on a population level. So you may not necessarily be the person at the population level that's making the decisions or running the specific organization, but in your practice will be stronger if you understand the epi of the community that you're in, if you understand the nature of your population, like the assessment of your population. So I think there's almost an opportunity for work together between public health specialists as well as family medicine to identify those specific competencies and how they might actually fit into training to ensure that in the course of practicing comprehensive family medicine, a family doctor may be able to pull in and draw in their knowledge of their community, epi, or their knowledge of their community inequities, whatever they might be facing, to be able to understand how that might be manifesting before them and with the patient that they're facing. I think it's also an opportunity for me to put in a plug that I do think family medicine and public health, I see them as siblings in arms, right? Essentially, as I mentioned, they're meant to be working together to try to keep things out of the hospital system. And so I think there are also opportunities to be explored there as to how public health and family medicine can work better in terms of what family doctors see on the ground shared with public health, and vice versa, what public health is seeing and pushing that to family doctors. I know a lot of that happens already, but we can always work on optimizing and enhancing that.
And to that point, how lucky we are that Ross Upshur is here. Ross, I don't know if you can wait, but Ross is our leader of clinical public health here at the University of Toronto in the Dalla Lana School of Public Health. He's also our interface with public health and family medicine, one of our greatest teachers and academic leaders. And I know that you guys are working together and you're going to solve the healthcare system, right?
Ross is also my department head at Dalla Lana, so.
Hey, Lawrence. Brian Schwartz, former family doc, former emerge doc, and former public health doc. You talked about the uniqueness of the college, and Risa, your remarks as well, comparing us with the United States. And I see it, you know, there are many roles, but two primary roles. One is kind of the Royal College model, where you are the standard setter and the certifier, and in some degrees, the regulator. And the other is the advocate, the supporter. Those can potentially be in conflict. How do you reconcile this? And congratulations on your appointment. I'm delighted that you're here and we're able to present to us. How do you reconcile that? And how do you become excellent at both without being in total conflict?
Well, thank you, Brian, for the congratulations. Thank you as well for your own hand in my career. For those of you who don't know, I worked with Brian at Public Health Ontario when I first returned from British Columbia. So grateful for the question and grateful for your support. I think it's important for me to highlight that that tension was something that was directly asked to me when I was actually, in the selection process for this role. They're like, how do you manage this tension? And I think where I've landed on so far, and the opportunity that we actually have to navigate as a community, is the idea that we are really trying to focus on what is best from our members. And not in a paternalistic sense, what I think it's important for me to share is sometimes on the standard setting side, having excellent standards actually indirectly benefits our members. If we choose to lower our standards, it actually isn't going to be, it doesn't go as well, right? So I think there are situations where when it comes to matters of standards and certifications, the college will fulfill its function in trying to make sure that those remain excellent so that we can continue to make sure that policymakers see family medicine as reliable, excellent expertise, because that in turn will actually support our members in the long run. It makes sure it gives us a gravitas. At the same time, on stuff that maybe is different from standards, then we need, on the matter of members' views on standards, that's where we really need to have sort of broader understanding conversations, et cetera, so that we all actually agree on what we're going to be putting forward as our best. But on matters that aren't involved with standards, I think it is totally fine for us to actually focus on the driving and the advocating of the stories that we're hearing from practices. So that's the balance I'm striking. It's, it ultimately is all in the service of members. It's just a question of, is it a matter of making sure that the standards are excellent and support them indirectly, or is it a matter of supporting them directly, at least in respect of their day-to-day practice environment?
Thanks. I think that speaks to the Canadian way of being polite and working together. And Jack, I invoked our conversation yesterday about all of the organizations in the States kind of getting at each other. And I think Lawrence just eloquently explained how it is not just as polite Canadians, but as I think good thinkers that we work together to solve these big problems. And we're very fortunate for that. Ozzy.
Lawrence, hi, we met today. So I'm Ozzy Mulvaney, I'm the undergrad director. So the word cloud is my worst nightmare, right? So my job is to get people to pick family medicine for a living. So I guess my question is, social media has helped highlight the crisis we're in, but it's also driving medical students away. And all I see on Twitter and Insta is all the awful things about family medicine. And I want to pick your brain about how we balance it. So at a particular meeting we had with the leaders of this group, I said, can you write one positive thing in your Twitter feed a day about family medicine? And I got these looks, because we want to be truthful, but at the same time, we have pretty amazing jobs in general. So I would like to pick your brain. How do we do this?
Great. Yeah, I know. Oh, cool. Sorry, everyone. I don't need to drive you all temporarily deaf. I apologize. It's an important question. I will say this is, and I've learned in my role. So I consider myself, I joke about being a recovering physician in a sense, because I've recognized, especially having worked in public health, that I'm not an expert in anything, and not an expert in everything. And I think there's generally this expectation that once you have your MDs, you're supposed to be able to answer questions on anything. I will fully admit to this group that I am not a social media guru, as you've probably told by my, lack of presence on Twitter, or at least I'm there. What you don't know is that actually that's more of a Potemkin Twitter, like, Sam Comtois, the communications group runs it for me. And I basically just say yay or nay. But as I understand it, there are algorithms and all these other things that there are ways to game that. So if we can figure out ways to game that, we can get a little bit more positive things out there. To the other question I think you're asking, which is how can we strike a balance between talking about how difficult it is versus the truthfulness? I think it's important for everyone. I mean, any relationship, friendships, marriages, they all go through rough patches, but they can still be overall good, right? And the trouble when you portray something, warts and all, is that the warts end up dominating the picture. So I think there is some room for us to actually really go back to first principles. And if insofar as I was going back to first principles with why does the college exist, I think it's also important to go back to, well, what is it about family medicine? What is it that keeps everyone still showing up at work every day, despite all the stuff that's happening? And there are still some things that can be drawn on. And if anything, that's fodder for all of us, and certainly all of us in the community, to continue driving us forward and knowing that our stories are going to drive change, and change it's for us and for our patients, most importantly. But also hopefully that learners will understand that this is, let's say it out loud, like family medicine is an awesome specialty, and hopefully that's the way it goes. So I think you need to strike that balance between digging deep, and I think we all have to dig deep in dark times. I think we all had to do that for the last few years, so there may not be much more digging that we can do, but I think we dig deep, and then we try to game whatever algorithm Twitter's got.
Strat plan.
In terms of gaming Twitter, I don't know. I was actually hoping Twitter would go, but I think in terms of celebrating medicine, that is a theme that I've been hearing throughout a lot of the consultations. And I think there's a lot that we can do to both celebrate what's good and also highlight what's in crisis at the same time.
Thank you. If I heard two things there, one is I could hear Bill Watson at St. Mike's and the family therapist in you talking about the marriages and how we can still survive. So I don't know if Bill's here today, but yay, Bill, and yay, you. And to Ozzy and all of our colleagues who are so diligently working to present family medicine in a positive light. Many of you know that we have our interest group in family medicine. The first in Canada started here at U of T and has spread across the country. One of the things I hope is that we will come together, all of the different organizations that are looking at promoting family medicine as a career choice. So we have our undergrad program directors across the country. I sit on the governance committee at the college, UJEC, that's looking at it. We have the Ontario College, we have the OMA, all of these people working toward a common goal, but not working together. And I'm hoping that that's something we can do. Ava.
Hi, I'm Ava Grenfeld. I'm a professor emeritus. It's kind of hard to say that with this department. We haven't met, but I think we're about to. I'm chairing the Honors and Awards Research Committee for the college. My question is a little bit tangential. We are clearly dealing with a health human resource crisis. And one enormous and untapped resource are, of course, the internationally trained health professionals. One hears about how obstructive so many of the governing bodies in medicine are in facilitating their engagement with the healthcare system. Can you tell us a little bit about what the college is doing in order to help facilitate their integration and add value to the Canadian healthcare system?
No, that's a great question. Very important question, in fact. And I think I highlighted it briefly that in pursuing systems change, I think international graduates are an important part and an important aspect. I know that we have been in conversations with the federal government as well as with MCC and the Royal College to look at how do we ramp up practice-ready assessments. One of the challenges, as I understand it, and I know a lot of people in the room probably may have more expertise on this than I do, is the idea that family medicine training by virtue of the nature of the way it's practiced is also incredibly diverse around the world. And so that makes it really hard to to simply look at credentials on a credentialing basis, which makes the practice ready assessment route the ideal route to actually assess and also support people's transition into the healthcare system. One of the challenges into training on the healthcare system, one of the challenges that I would identify, though, and this is a Canada-US thing that I've understood, is that because we are such a smaller country, we have such a crisis in family medicine is also a crisis in family medicine teaching. And so being able to quickly come up with people that will actually support and help people navigate in the form of practice ready assessments it is something that it's a rate limiting step that is a little bit more pronounced here in Canada than it is south of the border. But all that to say, you know, I think those conversations around making sure that we can actually support people to actually have those assessments and move forward, that work is actually actively being pursued at the college right now.
Thank you. I think Alice, only one question left. Sorry, guys, you get to come back after lunch.
Okay, well,
Sarah, before I introduce you, I just, okay, you know what? I'm not going to take that time. I'll let Tara go ahead.
thanks, Teresa. I'm Tara Karen, family doctor and vice chair for quality and innovation in this great department. So a different kind of theme for me, I was wondering if you could talk more about the college's strategic approach to what I think is one of the biggest threats to family medicine right now, which is the incursion and growing footprint of corporate, for-profit, shareholder-driven large corporations into family medicine. We know in a time where 1 in 5 people don't have a family doctor that governments are increasingly turning to those corporations to solve their problems. And I don't see them turning to family doctor organizations in the same way. And I'm wondering what your approach and thoughts are on that.
Well, I think the college is very clear that we support our current healthcare system. Just because it's having challenges doesn't mean you throw the values out, altogether. But I think what is interesting is as we are trying to gain further traction through our advocacy, that is a topic that we will be able to start inserting into more discussions. We just completed a day actually out on in Ottawa, May 1st and 2nd on Parliament Hill, met a number of parliamentarians, senators. I think we are really starting to make traction on the idea of team-based care and really reorganizing the public healthcare system and trying to highlight to them that in the long run, that is the system that is going to carry us through. It's the one that done right, we can use to drive equity, to move things forward for our patients, rather than the quick fix and frankly false promise of a lot of private solutions. So I think, again, going back to said, we're in the flail your arms part of the crisis phase right now, which is why I think we're seeing that. But you are very right that we do need to guard against it, and we do need to make sure that our messages are very clear that it's about fixing the system that we've got right now, because it's frankly, the values are some of the best in the world. So thank you.
I'm told we can have one more, and so I'm glad to give that to Sandy. But Sandy, before we do, I just wanted to share with everyone in the room that while we're in this healthcare crisis and manpower crisis, the government has recognized that we need more family physicians. It's always a little bit behind the time, right? Cut us off. We don't have enough. We know what's going to happen. It happens. But just last week, we learned that we may and probably will have something in the order of 40 new medical students. Yeah, 40, 45, 44. Okay, close. And something in the range of 40 new residents. So we are all going to have to dig deep in our roles as clinician educators, researchers, and also look for ways to expand our reach, to expand our teaching in a way that makes students want to be family physicians. And I know that you know what's happening across the country, and we look forward to working with the college in this. And last question to Sandy.
Okay. Hi, I'm Sandy Buckman. Had a few roles, but one has been as a CFPC president. And thinking back, I was very kind of inspired by your lecture and how you sort of even referred to strength and study and how it was coming together that really solved it and where we are today. I was also taken by the fact that you've really identified the systemic practice environments that are really the major barrier to students. Again, like everyone else, that emotional reaction to the word slide that you showed.
I'd like to know a little bit more about the College of Strategic Planning in terms of its outreach to all the other healthcare organizations, medical, all in our interprofessional colleagues throughout the country. If we're really going to solve the systemic problems in a way, we cannot do it alone as a siloed family physician organization. If our future is together, as your title of your talk is, our strength is being together. I think what's the vision about the interprofessional movements to really change the healthcare system with primary care, with family medicine as foundation?
That's a great question, and thank you for it, Sandy. We actually, prior to actually starting the process, we actually identified a number of phases within our current strategic plan. The first phase is obviously the development and drafting of the plan, and then it will go out for consultation. So within that, we identified lists and lists of stakeholders, including interprofessional organizations and representations, and we analyzed them based on three main axes in terms of impact, interest, and I can't remember the third one off the top of my head right now. But in essence, we basically ranked different organizations, and depending on where they were, they ended up within either the development part of the phase or the post facto. Basically, how they would engage with us as a college was how we anticipated engaging them through our strategic planning process. But all that to say and reassure that that definitely national organizations from other professions beyond family medicine were contemplated, and they will be providing input in either one of those phases into our strategic plan.
Thank you. That's okay. We need to wrap this up, and I know everyone needs a bathroom break, a coffee break. I wanted to share some reflections on this morning's session and your keynote, which is, in this department, we have such depth and breadth and commitment and talent. And we heard that in you as well today. So I think that if Walter was here, he's the kind of guy who could stand up and just talk, as Lawrence just did. He could talk about anything, anytime, about anyone, and anything in medicine. And you showed us that again today. So thank you for joining us. Thank you for being our keynote address and for kicking us off this morning. And we hope you'll come back soon.